All right, so I'd like to get started by welcoming everybody to this special class in International Comparative Drug Policy here at Georgetown University. It's in the Master of Science program in Addiction Policy and Practice. I know we have some colleagues from Brown University joining in as well. But one of the things I'd like to do, and the students here, I've said this joke a few times, they've been together as a cohort for a year. They're probably sick of introducing themselves, but I'd like, Doctor, for at least you to get introduced to the 9 or so students in the seminar. And I know we also have some colleagues from Brown as well, but we'll just take a few minutes to make introductions on the Georgetown side. So why don't we start with the folks in the room? Go ahead, guys.
Hi, I'm Julia. I graduated from Tufts in 2020, where I did psychopharmacological research on drug abuse changes in behavior.
I'm Ben. Thanks for being here. I'm originally from Greensboro, North Carolina, where my background is in social work and harm reduction direct services.
Hello, my name is Sarah. I have experience working in the harm reduction and the housing field before joining this grad program.
Hello, sir. My name is Bob Waller. My background's in law enforcement.
Hola, bom dia. My name is Gina. I'm a Spanish professor, and I am working at ONDCP as an intern this summer. Obrigado.
Good to meet you. Obrigado. Good to meet you all.
Great. And we also have 3 people who are joining us remotely from the class. So if John, Nikki, and Molly, in any order, could quickly introduce themselves, that would be great.
Good morning, sir. My name is John Mello. I'm an Army officer. I've been one for the last 23 years. Just finished an assignment working at the Office of National Drug Control Policy, where I manage the Mexico-U.S. drug policy portfolio. And for the last 10 years, I've served abroad working at embassies, U.S. embassies in Mexico, Honduras, and Brazil. Moving forward, the failed, what I call eradication policies that the U.S. likes to exert over their partners.
Melo sounds quite Portuguese.
It does, but it's actually Colombian. But I did go learn some Portuguese on behalf of the Army, and I spent a year in Brazil as a student.
Good to meet you.
Good morning. My name is Nikki Soda, and I work for the National Association of Addiction Treatment Providers. I do membership and advocacy with treatment centers all over the country. I'm also a person in long-term recovery, and very honored to have you here this morning.
Good to meet you.
Sorry, go ahead.
No, good.
Oh, I'm Molly McGrath. I currently work with the American Society for Addiction Medicine, which is a medical specialty society here. Great to have you.
Thank you. So that's the class, and you'll see it's interesting that we have, again, not in order of importance, we have a lieutenant colonel in the military, we have a retired police officer, people doing direct service harm reduction, people working on policy, people who've come to this line of research and practice from, like, for example, losing family members to addiction. So it's a really interesting and diverse cohort. And there are 2 other folks I'd like to quickly introduce before we get going, which is Regina LaBelle and Dr. Jody Rich. So Regina, if you could just hop in and say hi. I don't know if you've met Dr. Goulao before. I presume you're in the same orbit, but I know you'll be jumping in on the conversation today. So I wanted to have you introduce yourself.
Thanks so much. And thank you so much for visiting us, our class today. I know this is, a really great opportunity for all of them. And you have the privilege of speaking with them right at the end of this program, which is a 30 credit 1-year program. This is the last few classes they're taking. And I know that, they've heard a lot about the work that has been done in Portugal, and I'm sure they'll have lots of great questions for you. So appreciate your taking the time today.
Thank you, Regina. I think we never met before, but it's a pleasure to meet you here. And also my good friend, Jody. Yeah.
No, thank you. And Regina was the acting drug czar for over a year under President Biden and the deputy drug czar under Obama. So last but not least, Dr. Jody Rich, my research mentor and a man who just days ago got back from a long trip to Portugal. So if you could just introduce yourself, Jody. You're muted.
Thanks.
Oh,
You know, how many times do I have to make that mistake? It was too short a trip to Portugal because there's a lot of really exciting stuff going on there. And really it's a testament to Dr. Goulao, what he has accomplished there. And, you know, I mean, 20 years is not a long time in some sense. And when you look at the impact he's had, it's just remarkable. And, you know, I spent this week there and since then reflecting on what can we take from the Portuguese model and replicate in the US, because we certainly need to. And anyhow, I'm really looking forward to this discussion and to your questions and Dr. Goulao and Dr. LaBelle's replies. So thank you. Great job, Brenda.
Thank you. And I missed one of my students, Millie Patel. If you could just jump in. Sorry, Millie. I was 8 for 9.
No problem. Hi, my name's Millie. I'm originally from California. I graduated from UCLA about 2 years ago, and my background is in public health advocacy and clinical research.
Yeah,
thank you for being here.
Anyway, so all right. So with that said, I mean, I know that there's so much interest in this topic, but what I'm hoping you could do, Doctor, is, you know, when I was a chief of police in Vermont, I spent a lot of time dealing with the opioid crisis, and almost every meeting in a public forum, somebody would ask me when we were going to do the Portugal model. So what I hope you could do, I want to flip the script a little bit because we're coming on to models of decriminalization and legalization here in the US. Could you help us by understanding what the Portugal model is not? Because it's a catch-all. It has a big role in people's imagination. They point towards it rightfully as a great model, but I think sometimes they put a lot of their own freight into what Portugal must be. What could you say surprises you about what people think the Portugal model is, and what would you caution people that it is not? Does that make sense?
Okay. Thank you, Brandon. And first of all, thank you all for joining us. It's a pleasure, and I want to thank you for this invitation. It was also a pleasure to have Dr. Jody Rich with us 2 weeks ago, and we are now very, very close friends, and I hope that he helps things moving forward. But coming to your question, what I like to say is that people tend to talk about the Portuguese experience, mostly by the fact that we decriminalized the use of every drug 20 years ago, 21 now. But I would say that the Portuguese model is much more than that. Just to decriminalize, it's important because it tends to lower the stigma of people who use drugs, tends to be in favor of the approach of those people to the health and social facilities that are available to deal with them. But decriminalization alone would not lead us anywhere. So, along with decriminalization, and I will talk later if you wish about the way we decriminalize drugs. Along with the decriminalization, we have put in place a set of policies on prevention, treatment, having treatment available, easily accessible, for free for all those in need of it, a set of harm reduction policies, and the investment on reintegration of people. First of all, with their families, but also in the work world, trying to prepare them and to be and to facilitate the access to employment. It's important to say that our decriminalization is not a depenalization. Using drugs in Portugal is still prohibited, although it's not punished under the criminal law, but only under the administrative law. Something that we can compare to the use or not use of the safety belt when you drive. If you do not use your safety belt, the police officer still stops you, may impose a fine in place, may impose that you attend a training course for drivers, but you do not get a criminal record that stands for life and contributes for the stigmatization of people, turning difficult or even impossible to get a job, to get a loan, to buy a house, to buy a car, this kind of things. And on the other hand, having decriminalized drug use allows us to speak about this subject in any setting, in families, in schools, in workplace, and if someone has problems and needs any kind of help, it's easier that the people searches for it without fearing to have any kind of consequences for it. So, but in any case, it's important to insist in the idea that we did not liberalize or did not legalize the use of substances. It is still prohibited, although it's not under the criminal law. Well, for the first round, Brandon, I don't know if it was clear, this information. Probably I can move into explaining what happens to someone who is caught by the police authority.
No, doctor, I think we'd love to hear that. But to continue on, so I sort of set up that question when I said what the Portuguese model is and is not. You know, I was hoping you'd give the answer you did, which is it is not this depenalization or this blank check to take drugs. And I think that we're wrestling with that question in America. A lot of the decriminalization efforts go directly to disempower. In some ways, I'm trying to put this like the law is not empowered to stop the person who's possessing or using drugs in any way, civil or otherwise. So before we go on, could you take a minute to explain Portugal's rationale for stopping where it did? Right? I mean, Portugal is somewhat different than a lot of the models we're looking at now in America, which go further in decriminalization than Portugal. So I was wondering, you know, sometimes you limit the extent out of political reasons or as for horse trading to get something passed in the legislature, but sometimes there's a thoughtful scientific reason behind it. I was wondering if we could hear about Portugal's rationale.
Well, I'd say that we had some particular historical conditions in Portugal to move into that direction. First of all, the onset of drugs problems in Portugal occurred later than in most European countries, in most countries in the world, because as you know, we lived for a long time under a dictatorship in a very close regime, Salazar, maybe it sounds to you, with a very tough political police, censorship, with limited mobility for citizens. We were very isolated. And some movements that happened in other parts of the world, such as the hippie movement or the students' movement in France in the late 60s, did not touch us, did not reach us because it was filtered by that censorship. But in the last years of the regime, we were also dealing with the colonial war in our ancient colonies, Angola, Mozambique, Cape Verde, Guinea-Bissau, and so on. And almost all the young male population was sent there to serve as soldiers. And down there, a little bit like the Americans in Vietnam, drug use was tolerated or even incentivized. So most of those young guys developed some habits of using substances, psychoactive substances. When suddenly we had our democratic revolution in '74, our coronation revolution, with a huge change in Portuguese society, and shortly after, with a sudden openness, capacity to travel abroad, we became also an attractive destination for tourism. So suddenly we had a lot of contacts with people from other countries. And shortly after, we had the decolonization process with all those soldiers and settlers coming back to mainland, almost 1 million people coming back. We are 10 million inhabitants, roughly stable. So 1 million people coming back to mainland was quite a difficult moment to absorb all those people. But it's important to say that they brought literally tons of at least cannabis that was easily available in those countries. It was the most used substance. And when they came, they gave it away for free for their friends and relatives, and for us, we're here. I was 20 at the time, so I remember there was a kind of a curiosity, avidity to those new things who came with freedom. So there was an explosion of experimentation, cross-cutting all social groups. Everybody experimented at least cannabis. That became very popular. But shortly after, we had some criminal organizations that introduced all the other substances in our market to explore a new emerging market. So suddenly we had everything available, plenty of cannabis, but also cocaine, heroin, LSD, you name it, in a completely naive population about drugs. While other societies had the opportunity to learn how to deal with drugs, with the presence of drugs, we suddenly were confronted with their presence, knowing nothing about it. So it was easy to shift, to experiment this and that, and heroin became very popular and became a true epidemic in our society. In just a decade, it was almost impossible to find a Portuguese family that had no problems related to heroin use. We are talking about the end of the 70s, the beginning of the 80s, with the onset of HIV infection that started to spread among drug users and started to devastate this population. So drug-related problems became very present in everyday's life, like the use of substances, the public nuisance caused by it, with overdoses deaths, HIV infections, criminality related to drugs. We are happy we never had a big, violent criminality related to drugs, with those shootings and that movie scene. But in any way, those petty crimes, acquisitive crimes, were very present in everyday's life, were very disturbing for the population. So drug and drug-related issues started to to climb in the political priorities and the social priorities. And what is, in my view, it's important in that time, is that from the very beginning, people tended to think about drug use as an health issue rather than a criminal one. And in my view, it's important that it came from the fact that it was so transversal to the society. It happened among marginalized communities, among poor communities, racial minorities, but also among medium class, upper classes, political class, everyone. So, and in my view, it's important to have people from medium class, and we can imagine, for instance, a medium class housewife discussing with the priest, and the Catholic Church was important here also. Can imagine a lady saying, "Oh, my boy, my girl is not a criminal, is someone in need of help, someone in need of treatment, but is not a criminal and will not benefit from going to jail or prison by drug-related offenses." So that idea that problematic drug use was mostly a health issue made its way in our society, and all our policies were oriented into that direction. But in any case, in practice, I'd say that the police and the law enforcement approach was quite oriented to address people to healthcare facilities, to healthcare responses, rather than having as a priority to put people in prison. So it was, I would not say that it was a de facto decriminalization, but it was a little bit coming to that. In any case, only in 97, 98, as drug and drug-related problems were identified in polls as the first priority, first social priority identified by Portuguese people, then the government decided to invite a group of experts from several areas. Our head of the government was at the time António Guterres, who is now the Secretary General of the United Nations. And he invited a group of experts from judges to psychiatrists, medical doctors, nurses, well, a multidisciplinary group to whom they asked to make a proposal of a strategy to deal with the drugs problems. I was included in that group, so sometimes people tend to talk about me as the architect of the Portuguese policy. That's not true. I'm only one of the workers on it. I'm not the one with the idea to put together this set of policies. But in any case, we proposed a new way to address this drug supply side, but mostly the drug demand side, with a set of policies in terms of treatment, providing treatment easily accessible for free for everybody in need of it, with a complementarity between the state-run facilities that are mostly outpatient clinics and inpatient responses, such as therapeutic communities or detoxification clinics that are mostly on the social side, on the under NGOs, with a set of harm reduction policies, assuming that even when someone is still using drugs, he or she deserves the investment of the state in order to have a better life and a longer life. Some policies on reintegration, reinsertion of people who ever use drugs, and new ways also to address the preventive work, instead of having big campaigns, mass campaigns of universal prevention, having preventive work more focused on several groups in scholars, but also to some groups that, for any case, are particularly exposed to the drugs phenomenon, and addiction phenomena. All this based in the idea that we were dealing with a health and social issue rather than a criminal one. And accordingly, we proposed the decriminalization of drug use. It's fair to say that when the government invited us to build that strategy, the only boundary that was presented to us was, okay, gentlemen, you may propose whatever you want, but you must fit within the spirit of the United Nations treaties that, as you know, impose a prohibitionist paradigm in line with the prohibitionist paradigm. So, but nowhere in the treaties it is said that drug use should be criminalized, must be prohibited, but nowhere it is said that it should be criminalized. So what we found was a kind of a mid-term solution. That means keeping administrative sanctions, but taking mere use and possession for personal use out of the criminal system. We also proposed to establish a limit based on the amounts of substances that the person has on them. Of course, it is also always arbitrary. What we proposed was to make that boundary on the basis of personal use for 10 days. There's a table with different amounts for different substances. And if someone is caught in possession of an amount of substance or substances that is above the limit, the person is sent for criminal procedures, for a court of law, as before, up to the trial, up to the criminal system to establish if the person is trafficking or not, if that was only for personal use. But if the person has less than that amount, is taken to the police station as before. The substance or substances are apprehended by the police. They are weighted, and if the person has less than the amount that is established as a limit, it is just intimated to present to a panel that is called the Commission for Dissuasion of Drug Addiction, which is a panel of health professionals under the Ministry of Health, where he must present in the next 3 days. There's an assessment that is made by those health professionals about their condition of problematic users or just occasional recreational users, and if the person is a problematic user, someone addicted in need of treatment, is invited to join a treatment facility. And the panel also helps to book, to find a slot for treatment, and facilitates the access. But it's not compulsory. The person is free to refuse it and to say, no, it's okay, I don't want, I'm not interested on that case. And in the first contact, the panel usually only states, okay, please don't come here for the same reason, let's say in the next 6 months. Otherwise, I will have to apply you a sanction, which is an administrative sanction. For addicted people, for problematic drug users, that sanction is never a monetary fee. There's a long list of penalties that may be applied, such as to take off their driving license or to limit the mobility of the person, to impose, okay, you shall not attend that place, that cafe, or you must not join those friends, this and that. Or, for instance, let's imagine someone who is under treatment for HIV, following a treatment for HIV, and is missing his consultations. The commission may impose that, okay, you must attend your consultations and bring me the evidence, a piece of paper showing that you are attending every 2 months or whatever your bookings for those consultations. This allows us to increase the therapeutic compliance to specific illnesses or other. If the person, hopefully the vast majority of the people who are presented to those commissions are not addicted people, are occasional recreational users. Even then, and especially then, there's an investment of the commission in order to assess, to better understand the conditions and the problems that the person may have. For instance, okay, I have no problems with drugs. I smoke a joint with my friends on weekend, but in the conversation, in this interaction, in the history that is collected, we understand, okay, my parents are divorcing, or my father just lost his job, or myself, I am in trouble, I am facing some difficulties with, well, some eating disorders, or some problems with my gender choices, or whatever. And when identified, the commission has the capacity to invite these people to join other responses existing in society, not in centers for the treatment of drug addiction, but other kind of support that may help these people to deal with his difficulties. It's a kind of indicate prevention tool, where we can deal with some difficulties that occurring along with drug use may lead the person to a more problematic use later on. So, and this is quite effective. Of course, the person may assess, may enter the treatment system if needed spontaneously. This is only a supplementary gate for the system with the intervention of the policial forces. But of course, the system is available for all those who are in need of it, and that can join the treatment system by their own initiative. Well, maybe I can stop now, Brandon, and maybe there's a lot of doubts that our attendees may want to pose, and I'm completely available for it.
Yeah, no, thank you. It was interesting to hear that the guidance you got was your proposals must fit within the spirit of the UN treaties. That kind of helps explain why it was decriminalization but not prohibition. I think that's an interesting insight. And maybe I'd love to, if there are questions, we can definitely start taking them now, but you've touched on so many interesting things like law enforcement's role. It bespeaks questions about, were they receptive to it? Are they supportive of it? And then also you talked about stigma and stigma reduction. And I know now in the US, stigma is, it's a topic of growing interest in research, and everybody knows stigma when they see it. How to reduce it is another matter, but it seems like part of your goal was to address stigma. And then there's also the questions people have about how to measure success, right? What the measurements of success are in your model. So I'll table those. If anyone has any questions, they want to just jump right in and ask, we can do that. If not, I'm sure you can tell I have at least another hour of questions myself. So.
I wanted to just thank you for that presentation and overview. I thought, as Brandon just said, since this is a policy class, I thought it was really interesting to hear about the parameters, because the parameters that you were told, basically, that it had to fit within the treaties, because I think people tend to think of the treaties as being very kind of directive, and there is flexibility under the treaty. But the other thing, given that, I also wanted to ask, I know you were recently in Canada, and I wanted to ask what, it appeared to be a public event, what advice you would give to other countries considering implementing these types of policies, and, anything in particular for the government of Canada to consider.
I don't know if there's more questions to. Well, thank you for your queries. As to stigma, I believe that in the beginning, as I said, the spread of drug use was so transversal that every family had someone at home or in the close neighborhood with drugs problems, and people tended to think, okay, this is a illness, this is a disease, but I believe that people tended to say, okay, this is a disease, and this disease has the same dignity as other diseases, and the people who suffer from it have the same dignity as people who suffer from others. So there was, I would not say an acceptance, but there was an understanding attitude towards drug addiction as a disease, and this contributed, in my view, to lower the stigma to which people were devoted. And there's a very, very Latin position as well, a very humane approach, and that is devoted to this kind of situations by the southern people, by the people from Portugal and the other southern peoples in other countries. I believe that Jody could testify this attitude by the general citizen, general person on the street. Is not people tend to accept and work in the inclusion of people who ever had problems related to drugs. We are dealing with a chronic relapsing disease. And when Brandon asks, how do you evaluate, how do you measure the outputs of those policies? We measure by the total number of problematic users, by the capacity that we have to lower some indicators such as overdoses deaths, HIV or hepatitis infections, spread of those illnesses, but also by the capacity to include, to make an inclusive work, to have people back included in society, with the capacity to work, to build a family, to have a normal life, even if we assume that relapsing is always possible in a chronic relapsing disease, as we are assuming it is. As to Regina, well, we know that, as you said, last week I was in Canada, in the Waterloo University, and I had some contacts with people that spoke about the decriminalization that was decided in British Columbia recently. Well, I would say that the big difference is that when someone is caught, according with this new bill, when someone is caught with small amounts of illicit substances, it just gets a pamphlet with information where you can find any kind of response, such as treatment facilities, but nobody discusses what are the next steps and what are the responses available and what you can do since that moment. On the other side, I believe that we are a country with quite limited resources. We are not a rich country, but I think that what is important is that all our responses are coordinated, and we sit together to discuss how to optimize those resources. I must say that I have seen in several places in North America a number of facilities much higher than what we have here in Portugal, in the old country. Some places spend more money in one city than what we have available for the old country, but people do not sit together, do not discuss how they can articulate and optimize those responses in order to better fulfill the needs of the citizen. I think this is the key issue, and this is one of the elements that are really important in our reality, is to optimize, to work together, to think about the responses as a continuum according with the moment of the life of the citizen. So people circulate freely from the treatment facilities to harm reduction to reintegration. All this is an integrated approach, and I believe this is this optimization is the key of the good results that we have had. Of course, we did not solve all the problems of drugs in Portugal, but we have improved very dramatically all those results. Just to give you an example, during the 90s, we used to have, it was not a dramatic number, but we used to have at least one overdose there a day. That means 365 a year in the late 90s. Nowadays, we have 60, 70 overdoses deaths a year. Okay. HIV infections, of course, there are other factors. HIV is not as dramatically spreading as it was in those times. but it dropped dramatically in Portugal after we introduced harm reduction policies, as when we made available low threshold methadone programs, syringe and needle exchange programs that started quite early in '93. So there are a number of indicators that are really important. We estimate that we have the number of problematic users that was around 100,000 people by the end of the 90s. Nowadays, we estimate we can have 43,000 of all drugs. So we are quite comfortable with those policies, although we are now introducing or reinforcing some of them, such as safer user places. We started recently, just in 2019, drug checking to better understand what is really circulating and anticipating the arrival of the opioids that we anticipate that will come, such as fentanyl. And for the moment, we are not yet facing problems related to fentanyl, but we anticipate that it can come. We are training opioid users to use nasal naloxone if needed, to use it with their peers when needed. So we have the tools to develop new responses according with the moment. So that's how we try to deal with the, but Regina, better coordination between the different responses, an integrated set of responses, and someone in charge, responsible for all those responses. Someone who can be confronted by the government, by the political responsible, with the responsibilities for articulating all that work.
Thank you very much, Doctor. So, right, it's when you talk about somebody responsible, I think we're still wrestling with where that responsibility should lie in the US. And Regina, for example, was the acting drug czar, right? And so one would think by the title that person was responsible and had the power to move mountains, but I'm sure Regina could tell you some stories about how that proved kind of elusive. But we do have a question from Ben, a student here in the room.
Yeah, thank you so much. I sort of have a two-part question. Are the health professionals on the panel government or city employees? And what, if anything, does the government do to invest in the addiction workforce in Portugal?
I'm sorry, I didn't get the second part of your question.
The second part was, what, if anything, does the government do to invest in the addiction workforce in Portugal?
Well, the members of the panel were health professionals. Some of them already retired, but most of us were active professionals and responsible for different work. One of them was the leader of a psychiatric hospital. I was in charge of the treatment system addressing drug addiction. But most of them, we had a judge, two psychologists, someone from the university, one of them was a researcher in the University of Porto. But most of us were active professionals in the field of addictions. Only the leader of the group had nothing to see with drug addiction. He was professor in Stanford, former professor in Stanford, just arrived to Portugal. He used to say, "I know nothing about drugs," but he knew how to lead a working group. So he was very efficient anyway, and led us to very fast results in building that strategy. Once again, I'm sorry. I'm sorry that I didn't get the rest of the question.
What was the first question?
Does the government invest in the public health in an addiction workforce?
Yes, yes. It happened still before the approval of the strategy. We were already developing a network of centers, and the government was slowly investing in the spread, in the creation of those centers. But it was not a massive investment overnight. It was something very, very growing very slowly. But just to give you an idea, I became the responsible for the treatment system in '97. And when I took the lead, we had 16 centers all over the country. From '97 to '99, we came to 46 centers. So it was possible to have new professionals, to include new professionals, to have incentives, to have professionals joining this area. And then the strategy was approved, and in practice, in most of the areas, it was just to assume what had been done meanwhile in the development of the network for treatment. There was some, in the strategy, there were some issues that were clearly addressed. For instance, prior to the strategy, even among us, health professionals working on the field, we had still some of our colleagues resisting to the spread of substitution treatments for opiates. And saying, oh, we are just moving an addiction to another, it's not a real treatment. In the strategy, there was a clear recommendation for the use of opioid substitution treatment with methadone, with buprenorphine, whatever, as a valuable way to treat and to deal with addiction, and recognizing that one size does not fit all. So we need to have a vast several options to offer to our patients. And our system is based on that. We have, according with the situation, according with the phase in their lives, we have a vast vast options to offer, from residential work in community and in therapeutic communities to substitution treatment with high thresholds of excisions, to harm reduction context with low threshold substitution treatments available. So people can circulate and evolve through those responses according with the phase in their lives.
Doctor, could you say something about methadone policy in Portugal? I know that when COVID started, the Substance Abuse and Mental Health Services Administration in the US relaxed its methadone prescribing policies greatly, but it seems from what you said, you had a low threshold methadone policy for a while. Could you explain what Portugal's methadone policy is and maybe offer observations on whether it's the right fit or what makes it successful or what the US might do to copy it?
Well, we have treatment for opiate users, mostly heroin in our case. We have treatment programs available with a high level of excisions, with analysis control, with the excisions of abstinence for other drugs, namely for heroin or others during that treatment. With most of them with a limited time for use of substitution. And then we can try even to stop that substitution using detoxification units according by an agreement between the patient and his therapist. It is possible to try to stop even methadone or buprenorphine and move into a drug-free treatment, I'd say, with psychological support that can stand for a long time.
But can you say a little bit about where methadone is prescribed? Is it prescribed at the doctor's office, at only a methadone treatment center, at a pharmacy? If you could.
No, it's prescribed. No, methadone is prescribed at the doctor's office in the specialized units addressing the drug addiction. And it can be dispensed in several places. It can be in the centers themselves or in pharmacies by passing the prescription to the pharmacist for better convenience of the patient, or even in mobile vans that circulate around the city and where people can take their daily doses if they are not included yet in the conditions that are possible for take-home doses when abstinence is consolidated for several times, always in accordance with the prescribing doctor that can relapse, as you said, a little bit the exigence of the presence of the patients every day. Along with those treatments, those prescriptions in the context of treatment, there are low threshold methadone programs that are always prescribed by doctors, but without the sample control and the exigence of total abstinence as in the treatment programs. And we have included in those low threshold programs a huge number of people that increased a lot during the pandemic. As you said, the conditions to assess methadone were relapsed during the pandemic, but they are still, it was easier to assess in those days. But nowadays, there's a very important number of people taking their doses daily in vans that circulate through the city and where people can find them at given time, given hours, at given places. So it's very, very easy to assess them.
So the methadone policies you've described are much more relaxed and low threshold than US policies. And I know a lot of people on this call support that type of Portuguese policy. Yet the critics worry that it makes methadone prone to misuse, that methadone can contribute to overdose. Could you briefly talk about your experience with that and how you would address the people who point to those dangers in having a Portuguese style methadone policy?
Well, what I would say is that the methadone profile is much safer than other opioids. So even the discussions about diversion of methadone with take-home doses, or people will sell it in the black market, is stupid, because it's so easy to access for free. That diversion of methadone in our case is not an issue. People in need of it can easily access it, so there makes no sense to buy it in the black market. So, and I believe this is the way forward. It's to make the access to methadone, who has a much safer profile than other opioids, to have it easily available is one of the best tools to deal with the opioid crisis, as that one that you are facing nowadays. I think it's one of the best ways to counteract the opioid crisis is to have methadone easily accessible, uncomplicated access to methadone.
And I presume your buprenorphine policy is the same or even more relaxed as a drug with an even safer profile?
Yes, but it's we do not use as much buprenorphine in low threshold programs as we would like, because if methadone, we buy methadone bulk amount and we distribute and make it available on the treatment or harm reduction facilities. But as to buprenorphine, the patients have to pay for it, have to buy it in the pharmacies. So although we have programs, we have some thousands of people using buprenorphine, it is limited by the capacity to buy it at the pharmacist. Okay.
Thank you. Does Dr. Rich or anyone have any? I have more questions, of course, and so do the students, but if anyone has a question and they want to jump in, by all means.
So one thing that jumped out at me as a stark difference is, during COVID, we, in the US, we took our eyes off the ball. We got distracted by other things and we didn't really pay attention to overdose prevention as much as we had. And our overdose rates skyrocketed. In Rhode Island, we are, 30% higher than we were. It's just, it was devastating before. It's even more so now. And I was shocked to find out that there was no change in Portugal. And to me, there's two factors. One factor is, COVID, as with many other public health infrastructures, highlighted the weaknesses in our system, that we are not able to handle it. Of course, the other part of that is the fentanyl is really a game changer and has not hit Portugal yet. But still, they're at their worst, they were having 365 overdoses a year in a population of 10 million. And of course, now it's, 20% of that. In Rhode Island, we had more than 365. We had 400 plus this past year, and we are a population of 1 million, 1/10 the size. So we have tenfold rate of overdose deaths than they had at their worst. So, it's not just fentanyl. They are doing, they're doing a much better job on many levels, and they're not an affluent country. They, if we told people in this country, well, we can't really use buprenorphine because we can't really fund it, on a large scale, that would be unthinkable. The buprenorphine has become really our mainstay of for many people, and so we have funding. We have just our system is flawed in the way that. I think the challenge to us moving forward is how to identify those flaws, how to and take what we can from Portugal and translate it to the U.S. And I keep coming back to the, that like it's not the law change itself. It's not decriminalizing will not make a big change in itself, I don't believe, but it will start to erode that stigma. Start to, right now we have two messages. We say, if you're using drugs, well, they're illegal and you are a criminal and you need to be punished and incarcerated and have all the collateral consequences of that. At the same time, we say, oh, but actually it's a disease. So, come in, on the first instance, it's go away because we're gonna do bad things to you. In the second instance, it's, oh, come in, we're gonna take care of you because you have a disease. In Portugal, that's not it. You have, this is a medical and social problem, and we will use our medical and social tools to address that problem. And I think if we had that kind of refreshing message, that would begin to erode the stigma, and we could line everybody up and get everybody on the same page. I think that's the fundamental difference, and it's I think the way to get there here is the state by state. I think the Oregon initiative is very positive. This stuff going on in Canada is potentially very positive. On the other hand, there's a spin going on in Oregon. They've got a big homeless problem. They say, oh, look, here's what happens. You legalize drugs, you got a lot of homeless people. Well, there's a lot of homeless people for a lot of reasons, and the drug problem is not the only issue there. It's a lot of it has to do with the economy and COVID-related issues, and of course supply chain. Just kidding. Sort of, we can blame everything on supply chain, but we have the system where we have 50 states and we can experiment on each state at a state level. So I think that's the way to get there. We'll never get it through federal legislation, but we can get there one state at a time, and then show improvements. But it's a long.
No, Jody, I wanted to turn your observation into a question, because it's one that I had written down, and thank you for that. It's obviously very insightful. It seems like state level innovation and reform is the way forward, as Jody said. At the state and municipal level, law enforcement plays a really big role. They have a lot of weight and power in the policy debate. When law enforcement opposes policies, it can sometimes be a death knell. When they support policies, it can engender larger support. And it seems like a lot of Portugal's response involves collaboration from law enforcement. Law enforcement is one of the main touch points for entry into treatment. So I was wondering if you could at least tell us your experience with law enforcement at the policy level in Portugal, and any advice to people who are dealing with law enforcement in the US as an obstacle to policy change.
Well, thank you for that. I would say that in the beginning, after the approval of the law, of the decriminalization law in 2000, we had some reactions from the law enforcement forces that were not so happy with that idea. But with the evolution of the situation in the coming years, more and more supporters for this new policy came from the law enforcement side. Nowadays, we have to say that after the decriminalization entered into force, the efficiency of the drug supply side increased a lot. Because instead of spending all their time and energy with mere users or people in possession of small amounts of substances, they just pass those people to the health side, and they have the time and the means and the opportunity and the capacity to address the real sharks of drug trafficking. So instead of nowadays, by the end of the year, when law enforcement forces show their results, and they are mostly based on the amounts of substances seized, instead of showing grams or kilograms of substances, they show tons. They show big operations, big seizures in containers in open sea, in collaboration with their counterparts of other countries, and they are much more comfortable nowadays in doing that than in dealing with the users at the street level. So nowadays, law enforcement forces are one of the principal supporters of this new policy. Another thing I would like to say is that after the approval of the strategy, we had the strategy included the proposal of decriminalization. The strategy was approved by the government, but the issue of decriminalization had to be discussed at the parliament because it was not within the powers of the government. And it took almost 2 years between the approval of the strategy and the approval of the decriminalization law. We, the proponents, we took that period to organize a huge set of public sessions to discuss with the population what we intended to do, what was the proposal. And what I take from that period was a huge support of the common citizen. Big meetings in very big venues, very much crowded, and people enthusiastically supporting the idea of decriminalization. When it came to the parliament, things were different. There was a bipolarization between the left-wing parties supporting the idea of decriminalizing, and the conservatives was opposing and saying, Portugal will become a paradise for drug users. We will have planes coming to Lisbon every day with people to use drugs freely, or our children will start using drugs in very early ages, or even the relations with United Nations bodies was problematic in their view. By the end of the day, the bill passed, was approved with the left-wing parties' support. But nowadays, everybody agrees that it was a good step. Even those who voted against in those times, 20 years ago, nowadays support and assume that it was a good step that was given in 2001 when the decriminalization entered into force. So I think, of course, we are not trying to sell any kind of model, but we have the results of those 20 years and we are quite comfortable with them. So we are happy to share how we do it. And most important of it, we are happy to have you visiting us and watching in place how it happens. Because, you know, most of the people who comes to Portugal to take contact with our drugs policy is mostly interested in the decriminalization aspect. But when they leave, what they stress usually is the humane way that people who use drugs are treated in Portugal. And that is the difference, the humanism and some pragmatism that we have in dealing with the drugs issues.
Thank you. We have a few minutes left. I wanted to touch on overdose prevention sites or supervised injection sites or drug consumption rooms, whatever you want to call them. These have been a persistent policy topic in the US. As you know, Canada has had one for quite some time. Philadelphia made great strides towards opening one, but then could not for political reasons. And then New York City at the end of the last mayoral administration just very brazenly opened 2 sites. I know that they have not played a very large role in Lisbon and in Portugal, but they are something my research says maybe in 2017 you'd begun to open these sites. Again, you know better than me. I'm just winging it. But how do you see in your drug policy what role overdose prevention sites or drug consumption rooms have, and you know, where do they fit into an overall drug strategy in your country?
Okay, thank you for that. Well, as you said, the safe injecting sites are recent in our reality. It was foreseen by law since 2001, included in the decree law that regulates harm reduction policies, but it was the most problematic one to pass, to include in the bill. And it was, there was a condition to allow us to install this kind of facility. It was the agreement between the municipality and the central state. Okay. At that time, in the beginning, 2001, 2002, we felt the lack of this response for all those injecting in without hygienic or safety conditions. But there was no political agreement that allowed us to install it in Lisboa, in Porto, the big cities. So some years passed until we finally reached a consensus with Lisbon municipality to install one in 2007, 2008. And when finally we had that agreement, we came to the front, to the people in the front line in dealing with drug users, and asked them, okay, finally we have the conditions for it. Where do you think it's the most appropriate? And what we got from the frontline people: don't do that now, because injecting drug use is dropping so fast and we are reaching those results by other means, with the street teams, with the outreach work, approaching and educating drug users, that nowadays it's a wrong message that we are going to pass to the users. But just a couple of months or years later, we had the financial crisis that led us to huge difficulties, to more difficulties among people who use drugs, and we had a lot of relapses in that period. So we tried again, and once again, we sought in installing those responses. Once again, we had difficulties in reaching a consensus between municipality and the central state. So only in 2019, we managed to finally install a mobile injecting site here in Lisbon. And in 2000, during the pandemic, fixed place was installed because it was an obvious need of installation of this kind of device according with the circumstances that we were living. And nowadays, since we start to have results and they are completely admitted by the authorities, both municipal or national authorities. So this is was a supplementary response to all those existing previously.
It's so interesting to see that Portugal, which is a world leader in progressive drug policies, has a lot of the same obstacles when it comes to safe consumption as the U.S. and is only a few years ahead of the U.S. in implementing that type of policy. I know there's students. I got a lot of questions from the students. We have time for one or two more, and I would love for Regina to have the last word. But one of the things Regina and I were talking about on a sidebar is trafficking, right? So much of national level drug policy is about the supply side, is about trafficking. You alluded to changes in trafficking upon decriminalization. Is there any lesson you'd want to give to U.S. policymakers about that federal high-level trafficking strategy that Portugal has learned? Does that make sense? I'm saying it seems like that, like drug trafficking has changed in light of decriminalization. And you mentioned that at the municipal level, the police can do higher level, more focused work because they're not dealing with the small potatoes. Is that reflected in the national drug strategy?
Yeah, you know, differently from your organization, we do not have a big autonomy between the different provinces. They are just administrative, but they do not have local governments. So the important levels to deal with here is the national one and the municipal. In between, there's nothing important to be considered when taking decisions. At the law enforcement level, there's the forces in charge for important traffic authorities is the judiciary police that has a centralized government, a centralized body that leads with all the territory. No big differences between regions in dealing with traffic.
We have time for one last question, and I know it's one that my students are definitely interested in, and that's about harm reduction. In the United States, with the Biden administration, we're seeing for the first time a real federal interest in funding harm reduction, funding syringe service programs, funding, of course, naloxone, but really funding what people in the business would consider basic, even old school harm reduction, right? That was a long time coming in the United States. And it's still, if you talk to the people doing the work, way underfunded by the federal government. So much of harm reduction happens at the local and municipal level. It happens with non-government money. Could you share Portugal's vision or view? Could you share Portugal's harm reduction funding policies and maybe contrast them with the US and maybe just offer some insight into how Portugal views harm reduction as a federal or municipal effort?
We base the development of our responses according with the diagnosis that we make in each region. We have 18 districts here in mainland Portugal. We have plus Madeira and Azores islands. But here we have 18 districts. On each of the district capitals, we have a unit that we call the Center for Integrated Responses that has the responsibility to offer the responses in terms of treatment, prevention, harm reduction, and reintegration in their territory. Okay. From time to time, from every 4 years at least, that unit must call all the partners from education, from the police, from the social affairs, all the representatives of the different areas of intervention, and together, using the data available for the activity or the data on each one of the areas, they must make or update a diagnosis of needs. Okay. According with it, priorities are defined. Priorities are usually different in big cities like Lisbon or Porto, Coimbra, in terms of needs, than the needs that are identified in smaller cities. In most of them, priority would be preventive work, rather than harm reduction work. In big cities, the needs for harm reduction facilities and responses is usually higher. But according with that, and after having the assessment of needs, up to the group of the partners to identify who they identify a given gap in the responses to the population. Who among us is able to respond to this gap? If no one has the conditions, the means to respond to those gaps, we can launch a call for tenders for NGOs to apply and to respond to that gap. Okay. Usually, in the big cities and in these times, the main gaps that are identified are in terms of harm reduction, approaching most vulnerable populations and how to deal with them, how to work in terms of safer use. So some facilities such as those safe injecting sites that have been installed recently are a result of this diagnosis, and they are explored by NGOs that won their calls. I don't know if it's clear what I tried to explain.
It seems like the harm reduction policies are play out at the state, the equivalent of the state level in Portugal.
Yes, the means are administered at state level. Okay, we have a given budget, but then to apply it, we have to prioritize according with the needs. We score the applications that we have from all over the country, and according with the score of importance that this or that response should have, we launch a call or not.
Got it. Thank you very much. We are at time and we're conscious of your time. I don't know if Regina and Jody have any closing remarks, but we can wrap up.
I just wanted to thank you so much for coming, and we really appreciate your taking the time. And, you know, in the future, as I plan out where the future of our program is, we'd love to take a visit, come to visit Portugal sometime. So that's on my list for the future, but thank you so much for your time.
Did students want to know if there's an alumni clause for that, the graduates? Sorry, doctor, go ahead. No, I'm sorry, doctor, please.
No, I was just saying, Regina, that you are very much welcome. If you want to visit us, we'll have the pleasure to escort you and to show you what we do. As we did with Jody, which we had the pleasure to have with us. So sure.
So thank you very, very much. And I hope we can stay in touch. Thank you.
Regina, I would just warn you about two problems when you go and visit. First of all, the food is incredibly delicious. And second of all, the wine is incredibly delicious. So you have to be careful of that. But no, it's really, you know, I've been reading and thinking and talking and hearing about this for a decade. And to go and see it in person and talk to the people involved, it was just a whole different experience, and really, you know, solidified in my mind what's really going on, and what you know, what a lot of potential we have to help our issues in the U.S. I think, you know, I hope they don't get hit by fentanyl. I fear they will, and I think they will have to make some adjustments. But I think they're in a much better shape coming into fentanyl than we were, and they don't have the you know, they don't have the Purdue Pharma problem. They don't have direct to consumer advertising. They don't have advertising to physicians, and because they treat this as a disease, I think the general medical providers are educated, understand about opioid use disorder, and of course wouldn't, you know, I think that's why we got into such trouble in this country, because we never taught it in medical school. Doctors didn't know how to, they didn't understand what the disease was. They didn't recognize it when it started popping up in their patients. You know, we got caught with our pants down, and we got spanked. So, Joao, always great to see you. And great to see the enthusiastic faces in of the students. So,
thank you, Jody. Thank you, Regina, and thank you, Brandon, and thank you all for being with us. It was a pleasure, and I hope that you can, in fact, visit us. As Jody said, I think it's the only way to better understand how it works, how it has been working with us. And I hope that you can manage to deal with this terrific epidemic that you are having now, and can go through it. And once again, what I think it's important is to treat people with dignity, with as humane as possible, instead of just trying to pursue them. And so I think it's the best way is to treat as complete human beings. So it was a real pleasure to be with you, and thank you once again for the invitation.
Thank you.
Muito obrigado.
Obrigado a você.